Welcome to the Deep Dive. Today we're tackling a really significant clinical challenge, one we often see in orthopedic practice, avascular necrosis, sometimes called aseptic osteonecrosis.
That's right. It's a condition with pretty serious implications for patients. We're going to delve into how we understand it today and specifically look at hyperbaric oxygen therapy as a potential treatment.
Exactly. Because for orthopedic surgeons, and really any medical specialist dealing with bone health, avascular necrosis is complex. It's often progressive.
Absolutely. At its heart, it's about blood supply disruption,
Yeah.
usually to the femoral head, the ball part of the hip joint. But other bones can be affected too.
And that disruption,
Yeah.
the lack of blood flow, what does that actually do to the bone tissue?
Well, when the blood supply is cut off, the bone cells don't get oxygen or nutrients. They start to die.
Okay.
This weakens the bone structure and eventually it can, well, collapse. The source material we're drawing from today, excerpts from the Undersea and Hyperbaric Medical Society's Indications Manual, really highlights that hypoxia, that lack of oxygen, is fundamental here.
It's hypoxia. Got it. And you mentioned the femoral head is common, but the manual says it's not just a hip problem.
No, definitely not. While the hip is number one, you can see it in the knee, the femoral condyles, or the shoulder, the humeral head, even smaller bones in the foot and ankle, talus, calcaneus, navicular, places where the blood supply is maybe a bit tenuous to begin with.
Right. Vulnerable spots. So given the risk of collapse and the effect on mobility, who are we typically seeing with this condition in our clinics?
The manual points out it often hits people in their active years. Think 40s, maybe 50s.
The relatively young.
Exactly. And that obviously has a huge impact on their quality of life. Progressive disability isn't uncommon, and it can lead to that femoral head collapse requiring surgery.
There's an economic impact too, I imagine. People in that age group.
Oh, definitely. Lost work productivity, disability. It adds up. The numbers are significant too, maybe 20 to 30,000 new cases a year just in the U.S.
Wow.
And unfortunately, the rate of total hip replacements for this condition seems to be increasing.
That is a major burden. So when we suspect a vascular necrosis, say in the hip, how do we stage it? How do we classify the severity? I know the manual mentioned the Ficat system.
Right, the Ficat classification. It's been around a while, based mainly on standard X-ray findings.
Okay.
It goes from stage I, patient might have pain, but the X-ray looks normal, all the way to stage 4, where you see clear collapse of the femoral head, narrow joint space, arthritis, essentially.
So X-ray based. But hasn't imaging moved on?
It has. While Ficat is still used, maybe for context or general staging, MRI magnetic resonance imaging is really the gold standard now, especially for early stages.
Why is that?
It's just much more sensitive. It can pick up changes inside the bone marrow, edema, things like that, long before they show up on an X-ray. Crucial for early diagnosis.
Makes sense.
Yeah.
Okay, so that gives us a way to understand and stage it. Now, before we dive deep into hyperbaric oxygen, what are the sort of conventional treatments we typically consider?
Well, it really depends heavily on the stage. Early on, you might try medical management.
Like what? Painkillers?
Yeah, analgesics for pain, maybe anti-inflammatories. Some doctors have explored other things too, like anticoagulants, vasodilators, even statins and bisphosphonates.
Bisphosphonates, like for osteoporosis.
Exactly. But as the manual notes, these drugs often don't fix the underlying blood supply problem. They might help symptoms, but that's about it.
And bisphosphonates have their own potential issues, right?
They do. The big one being bisphosphonate-related osteonecrosis of the jaw, or BRON-NJ. It's a rare but serious side effect. So medications are often just part of the picture, usually not the whole solution.
Okay, so if medications aren't enough, what about non-surgical procedures?
There are a few things. Extracorporeal shockwave therapy is one.
Like they use for kidney stones or plantar fasciitis.
Similar principle, yes. Delivering focused energy waves to the bone. Some studies show positive effects, maybe improving staging or clinical outcomes.
Right.
But the success rates haven't generally been as high or consistent as you see with shockwave for, say, non-healing fractures.
I see. Anything else non-operative?
Pulsed electromagnetic fields, PEMF, that's another one. The idea there is to stimulate bone healing, maybe protect the cartilage.
How are these typically used?
Often as adjuncts, especially early on, trying to stabilize things, maybe buy some time, delay the need for surgery.
Right, delaying surgery. Which brings us to the operative side. What happens when non-operative options aren't cutting it, or the disease is more advanced?
Then surgery becomes the main consideration. Core decompression is a common one, especially in earlier Ficat stages like I or II.
Explain core decompression. What does that involve?
It's essentially drilling. creating one or more channels into the affected area of bone, the necrotic part.
And the thinking behind that.
It's about reducing the pressure inside the bone, the interosseous pressure. That pressure can build up because of the swelling and ischemia. Relieving it might improve blood flow and should definitely help with pain. Think of it like decompressing a compartment syndrome, but within the bone itself.
Okay. Does it work well on its own?
It can be effective for pain in early stages, but for longer-term success, especially with larger lesions, it's often combined with other things.
Like?
Well, like hyperbaric oxygen, which we'll get to. Or sometimes surgeons augment the decompression by injecting biological materials into the drilled channels, maybe platelet-rich plasma, PRP, or bone marrow aspirate concentrate, trying to boost the local healing response.
Stimulate regeneration?
Yep.
Makes sense.
Yeah.
And what if the femoral head is already badly damaged, collapsed?
Right. If you've got significant collapse and secondary arthritis setting in, then total hip replacement, total hip arthroplasty becomes the most reliable option.
The definitive solution.
Pretty much, yes. It's
Yeah.
very effective for pain relief and restoring function. But, and this is a big but, especially for those younger patients we talked about.
You want to avoid it if possible, or at least delay it.
Exactly, because hip replacements don't last forever. Younger, more active patients might face revision surgeries down the line, so there's a real push to find ways to preserve the native hip joint for as long as possible.
Which leads us perfectly into the main topic, hyperbaric oxygen therapy. The UHMS manual suggests it has a role. Where does it fit in this treatment picture?
The manual points to two main windows of opportunity, let's say.
Okay.
First, in the very early stages, Ficat I II. Here, the hope is maybe achieving, well, significant recovery, not just feeling better, but actual imaging, improvement, healing.
A potential cure almost.
Potentially, yes, in some cases. The second window is a bit later, maybe early Ficat stage 3, before major collapse happens. Here, the goal might be more about buying time.
Buying time before that total hip replacement.
Precisely. Delaying the inevitable, perhaps. It's especially valuable, again, for younger patients.
That buying time idea is really compelling. How is hyperbaric oxygen supposed to actually work in a vascular necrosis? What's the science, the proposed mechanism?
It's multifaceted, really. The most obvious thing is you're breathing 100% oxygen under increased pressure.
Right.
This massively increases the amount of oxygen dissolved in your blood plasma. So much more oxygen gets delivered to tissues, even those with poor blood supply, like the ischemic bone in AVN.
So directly counteracting the hypoxia.
Exactly. It fights the oxygen starvation. It also seems to reduce edema, the swelling within the bone, partly through vasoconstriction, which sounds counterintuitive, but it helps reduce swelling and leakage.
Less swelling means less pressure inside the bone.
That's the idea, reducing that intraosseous pressure, which, as we said, can improve blood flow further and relieve pain. It helps break that vicious cycle of ischemia, swelling, and more ischemia.
Okay, so better oxygen delivery, reduced pressure, anything else?
Yes. It's also thought to stimulate angiogenesis.
New blood vessel formation.
Correct. Which is absolutely critical for trying to reestablish a healthy blood supply to that damaged bone.
That makes sense. Is there an effect on the bone cells themselves, the remodeling process?
There appears to be. Evidence suggests HBOT can influence that balance between bone building and bone breakdown.
Osteoblasts and osteoclasts.
Yep. The very same. It seems to promote the activity of osteoblasts, the builders, while suppressing osteoclasts, the demolishers.
Shifting the balance towards repair and regeneration.
That's the goal. The manual even cites a study showing HBOT increased levels of something called osteoprotogerin.
What does that do?
Osteoprotogerin basically puts the brakes on osteoclasts. So more osteoprotogerin means less bone breakdown. It all points towards helping the bone heal itself.
Interesting. Any effects on inflammation or oxidative stress? Those are usually involved in tissue damage.
Yes, there's evidence for that too. HBOT seems to modulate certain inflammatory markers like TNF-alpha and IL-6 and also reduce oxidative stress. Both of those processes are implicated in driving a vascular necrosis forward.
Wow, okay. So there's a pretty solid biological rationale. What about the clinical evidence? Does it actually help patients?
There's a growing body of evidence, yes. Several studies have shown radiographic improvements, actual positive changes on MRIs or X-rays, especially in earlier stages.
And symptomatic?
Patients report less pain, better range of motion. There was a meta-analysis mentioned that pooled data from multiple studies.
What did that find?
It showed significantly better clinical efficacy, so better outcomes for the groups getting hyperbaric oxygen compared to control groups just getting standard care.
Any specific study results stand out?
Well, the manual mentions one study with an 81% success rate at a 7-year follow-up for the HBOT group, much higher than controls. Another found that after a year of HBOT, something like 90% of early-stage patients, Ficat III, and maybe 50% of early Ficat III patients, were still surgery-free 4 years later.
That's quite impressive, especially avoiding surgery.
It is, and there's also evidence, as we touched on with core decompression, that using HBOT after that procedure can give even better results, particularly for more advanced lesions. It seems synergistic.
Does it work for AVN outside the hip?
Yes, positive results have been reported for other sites too, the femoral condyles in the knee, the humeral head in the shoulder. It's not just limited to the hip.
The manual mentioned a European consensus finding, a 2B evidence level. What does that mean for clinicians?
Right. The 10th European Consensus Conference on Hyperbaric Medicine gave it a level 2B recommendation for femoral head osteonecrosis.
Level 2B, so not the absolute strongest evidence, like multiple large randomized trials,
But still indicates fair evidence. It suggests the data is pretty consistent and points towards a likely benefit. It's enough for a major consensus group to say, yes, this should be considered. It adds weight to using it.
Okay. So based on all this, what are the key recommendations from the UHMS manual about using hyperbaric oxygen for vascular necrosis? Are there prerequisites?
Yes, the manual is clear. HBOT should be considered as a therapeutic option. But, and this is crucial for appropriately selected patients, patient selection is key.
What defines an appropriate patient?
2 main prerequisites are highlighted. First, proper staging is absolutely essential.
Back to Ficat or MRI staging.
Exactly. The recommendation is strongest for early stages where you might see just some subtle edema in the spongy bone on MRI. Critically, they warn against using it to postpone necessary surgery if there's already significant collapse of the cortical bone. Don't delay joint replacement if it's truly needed.
Makes sense. Don't chase something if the bone structure is already gone. What's the second prerequisite?
Lifestyle changes, or perhaps better termed protective measures.
Such as?
For weight-bearing joints like the hip or knee, minimizing stress during treatment is vital. That often means using crutches, reducing weight bearing.
Taking the load off.
Precisely. And addressing other factors if the patient is overweight, weight reduction is advised. And absolutely quitting smoking. Smoking is terrible for circulation and bone healing. These things optimize the chances of recovery.
Right, a holistic approach. Okay, what about the treatment itself, the actual hyperbaric sessions? Does the manual suggest specific protocols?
It does offer some suggested schemes, mainly based on the Ficat stage for the femoral head.
Can you outline those?
Sure. For stage 1, where the goal is ideally full healing, they suggest maybe 30 to 40 treatments.
How long are the treatments? What pressure?
Typically 60 to 70 minutes, sometimes up to 90, at a pressure of 2.0 to 2.5 atmospheres absolute ATA. Some protocols might include a short air break within the session, then follow-up MRI and ortho evaluation about a month after finishing.
Okay. What about stage 2?
For stage 2, aiming for lesion resolution, it's similar initially, 30-40 treatments, then a break of about 20-30 days, then another block of perhaps 20 treatments, followed again by MRI and ortho assessment a month later.
A more intensive course.
A bit more, yes. And for stage 3 of the day, or potentially worse, where you're assessing if you can delay surgery.
The buying time scenario.
Right. The protocol might follow the stage 2 pattern, and it could even be repeated maybe once or twice at 4 to 6 month intervals, depending on how things look on MRI and clinically. They specifically mention considering this for kids who get AVN from high-dose steroids during chemotherapy.
Okay, these are quite involved regimens. 30, 40, even 60 sessions potentially. How do you monitor progress and decide if it's working or if you should continue?
The manual suggests a utilization review after about 40 treatments. That includes getting a follow-up MRI, but importantly, waiting at least a month after the treatment's finished to get that MRI.
Why the wait?
To allow time for the biological effects to manifest as visible changes on the imaging. The MRI is critical, though.
For diagnosis initially, but also follow-up.
Absolutely. It helps assess fracture risk, rule out other things, identify prognostic factors like how much bone marrow edema there is or if there's fluid in the joint. Comparing the before and after MRIs, along with clinical scores like the Harris Hip score or just a simple pain scale, that's how you gauge effectiveness.
Got it. MRI plus clinical picture.
Now, you mentioned kids with chemo-related AVN. The manual briefly touched on other contexts, too.
Yes, just briefly. It noted potential benefits in AVN linked to sickle cell anemia,
Okay.
dysbaric osteonecrosis, which affects saturation divers.
Right, the Benz connection. Certain rare genetic conditions called interferonopathies, and as we said, chemotherapy-induced AVN in children and adolescents. So the potential application might be broader than just the typical idiopathic or steroid-induced cases in adults.
Fascinating. Well, this has been an incredibly thorough look at avascular necrosis and where hyperbaric oxygen therapy might fit in, especially relevant for us in orthopedics. If you had to boil it down, what's the key takeaway message for our colleagues listening?
I'd say the main takeaway is that hyperbaric oxygen therapy is a genuinely promising option for avascular necrosis, particularly if you catch it early. It really does have the potential to improve outcomes, reduce pain, and maybe, just maybe, help patients avoid or delay major joint replacement surgery.
And the crucial points for us as clinicians when we're thinking about recommending it.
Careful patient selection, that's paramount. Getting the staging right. And remembering it's usually part of a bigger picture combined with things like reducing weight bearing, quitting smoking, and sometimes procedures like core decompression. It's rarely a magic bullet on its own, but a powerful tool in the right context.
A comprehensive approach. So, wrapping up this deep dive, let's think ahead. Avascular necrosis seems increasingly recognized, and its impact is significant. What are the next steps? Where does the research need to go with hyperbaric oxygen? How do we better integrate it to really optimize things for our patients?
That's the big question, isn't it? Refining protocols, identifying responders earlier, maybe combining it with newer biologics. There's a lot still to explore, understanding the synergy with other treatments better.
Absolutely. It's definitely an evolving field. We certainly encourage you out there to keep looking at the research, the guidelines, and thinking about how these tools can best serve the people we treat. Thanks for joining us for this in-depth discussion.